Hello. Today, lecture will address the behavioral objectives for week 1. Please note, this is part B of the lecture. There is a part A. This file is so large, it needs to be presented in 2 parts. Please make sure to watch both parts to avoid missing any critical information. Let's begin. We will be talking about physical assessment. You will be tested on this chapter as well as the media presentation screened in clinical orientation. When we're doing a physical assessment, initially you want to establish a setting for communication. Introduce yourself, establish parental roles, ask how to address the parents, ensure privacy and confidentiality, encourage talking, use open-ended questions, direct the focus, listen and observe with cultural awareness. Use silence and empathy to avoid communication blocks. Provide anticipatory guidance and consider the need for a professional interpreter if you do not speak the language of the family that you are interacting with. We want to encourage parents to talk. Interviewing parents not only offers the opportunity to determine the child's health and developmental status, but also offers information about factors that influence the child's life. Whatever the parent sees as a problem should be a concern of the nurse. Do not exclude the child during the interview. Communicating with children. Make communication developmentally appropriate. Get on the child's eye level. You don't want to be hovering over them. That can be scary. Approach the child gently and quietly while involving the parent or the caregiver. Always be truthful. Give the child choices as appropriate. Include play anytime that's possible. Nursing care guidelines communicating with children. Allow the child time to feel comfortable. Avoid sudden or rapid advances. Also avoid making really crazy broad smiles, extended eye contact, and any other kind of gestures that can be threatening. Talk to the parent if the child is initially shy. Often with little kids, if you talk with the parent first and then slowly start talking to them, you'll be more successful. Communicate through transitional objects like dolls, puppets, and stuffed animals before questioning a young child directly. Give older children the opportunity to talk without the parent present. Assume a position that is at eye level with the child. Speak in a quiet, unhurried, and confident voice. Speak clearly, be specific, and use simple words and short sentences. State directions and suggestions positively, meaning tell the child what you want them to do instead of what you don't want them to do. Tell them to stay still versus don't move. Offer a choice only when one exists. Be honest with children. Allow children to express their concerns and fears. Use a variety of communication techniques. Nursing care guidelines communicating with adolescents. Here you want to build a foundation and spend time with them. Encourage expression of ideas and feelings. Respect their views. Tolerate differences. Praise good points. Respect their privacy. Set a good example. You want to communicate effectively. Give them undivided attention. Please make sure that they can see you are listening to them. Be courteous, calm, honest, and open-minded. Try not to overreact. If you do, take a break. Avoid judging or criticizing. You also don't want to be giving them the third degree with continuous questioning. Choose important issues when taking a stand. After taking a stand, think through all of the options and then make the expectations clear. Here we're going to talk about some creative communication techniques with children. They include verbal techniques and nonverbal techniques. So first, the verbal ones. You can use the technique of I messages. Here you can relate a feeling about a behavior in terms of I. Describe if the effective behavior had on a person. You want to avoid using you. Here you can say something like, I am concerned about how the treatments are going to because I want to see you get better. Versus you are being uncooperative. Third person technique. Here you can express a feeling in terms of a third person. This is less threatening than directly asking children how they feel because it gives them an opportunity to agree or disagree without being defensive. Facilitative response. Here you want to listen carefully and reflect back to the patients the feelings and content of their statements. Responses are empathetic and non-judgmental, and they legitimize the person's feelings. Storytelling. Using the language of children to probe into areas of their thinking while bypassing conscious inhibitions or fears. The simplest technique is asking children to relate a story about an event, such as being in the hospital. Mutual storytelling. Here, this reveals a child's thinking and attempt to change his or her perceptions or fears by retelling the story, but it's a little bit different. This tends to be more therapeutic than basic storytelling. What you can do here is begin by asking the child to tell a story about something. Then you will tell another story that is similar to the child's tale, but with differences that will help the child in the problem areas. Bibliotherapy. Here you can use books in a therapeutic and supportive process. Provide children with an opportunity to explore an event that is similar to their own, but sufficiently different to allow them to distance themselves from it and remain in control. General guidelines for using bibliotherapy are: assess the child's emotional and cognitive development in terms of readiness to understand the book's message. Be familiar with the book's content and the age for which it's written. Read the book to the child if the child's unable to do so. Explore the meaning of the book with the child by having the child retell the story, read a special section with the nurse or parent, draw a picture related to the story and discuss the drawing, talk about the characters, and or summarize the moral or the meaning of the story. Dreams. Dreams often reveal unconscious and repressed thoughts or feelings. Ask the child to talk about a dream or nightmare. Explore with the child what the meaning the dream could have. What if? Encourage the child to explore potential situations and to consider different problem-solving options by asking them, what if? 3 wishes. Here you can ask, if you could have any 3 wishes in the world, what would they be? If they say they already have everything, then ask them specifically about the wishes that they had. Rating game. Use some type of rating scale. It could be numbers or happy to sad faces, and have the child rate an event or feeling. Word association game. State keywords and then ask a child to say the first thing that comes to their head. Start with neutral words and then maybe start introducing words that might be a little bit more anxiety and provoking. Sentence completion. This is when you're going to present a partial statement and then have the child complete it. An example of this would be, things I like best about school is, or things I like least about school is. Pros and cons. Here you can select a topic like being in the hospital and then ask the child to say 5 good things and 5 bad things. Next, we're going to talk about nonverbal techniques. Here, one is writing. Writing is an alternative communication approach for older children and adults. Specific suggestions include a journal or diary, writing down feelings and thoughts that are difficult to express, and even writing letters that are never mailed. Drawing. Drawing is one of the most valuable forms of communication, both nonverbal from looking at the drawing and verbal from the child's story of the picture. Children's drawings tell a great deal about them because they are projections of their inner selves. Spontaneous drawing involves giving the child a variety of art supplies and providing the opportunity to draw. Directed drawing involves a more specific direction, such as draw a person or the 3 themes approach. And this is when you state 3 things about a child and ask the child to choose one and draw a picture. Please feel free to look at the table in your book to go over the guidelines for evaluating drawings. Magic. Here, if you happen to know how to do simple magic tricks, this is a great way to establish rapport with the child. Here you can also use this to encourage compliance with health interventions. You can use this for distraction during painful procedures. Although the magician may talk, no verbal response from the child is required. And lastly, play. Play is the universal language and work of children. It tells a great deal about children because they project their inner selves through the activity. Spontaneous play involves giving a child a variety of play materials and providing the opportunity to play. Directed play involves a more specific direction, such as providing medical equipment or a dollhouse for focused reasons, such as exploring a child's fears of injections or exploring family relationships. Next, we want to talk about the history of the history component of the history and physical. History taking. This includes chief complaint, history of present illness, family history, the interval history, which includes diet, previous illnesses, injuries, or operations, allergies, medications, immunizations, and growth and development. The general approach to examining a child includes the sequence. And when we're looking at the sequence, know that it's going to be different than from the typical head to toe for the adults. Usually, we are going to assess the child to accommodate their developmental needs. You want to use communication techniques, play, and parental assistance to complete the examination. The goals is to minimize the stress and anxiety associated with the assessment, foster trusting nurse-child-parent relationships, allow for maximum preparation of the child, preserve the security of the parent-child relationship, and maximize the accuracy of assessment findings. Physical exam. So first we're going to talk about the growth measurements. Recumbent length. Typically we do this for infants up to 36 months of age, plus the weight and a head circumference. So recumbent length is they are laying down. A standing height plus weight and a body mass index is typically 37 months. You want to properly put it on the correct growth chart. You will select the charts by gender if they are premature. Please note that values less than the 5th percentile or more than the 95th percentile are considered outside the expected parameters for height, weight, and head circumference. Please refer to the growth charts on this CDC website. Growth measurements include a physical examination focused on length, height, weight, skin fold thickness, and arm and head circumference. Assessment of growth is measured against the standard growth charts to determine a child's status in comparison with other children of the same age. So if you are utilizing the growth chart that is birth to 36 months, you need to use the length chart. So the child needs to be laying down between 24 and 36 months. If you are using the height chart for 2 years to 20 years of age, when the child is 24 to 36 months of age, you will measure them standing up. The nurse may use a measuring board device, or when the child is laying down on the table paper, you can mark the crown of the head, and then you want to straighten the legs out so they're fully extended and mark the bottom of the feet. And then you can easily measure the distance between the 2 points. In older children, the height is measured with a child standing upright with the shoes off, and you want them standing tall, and their head should be against the wall, and their head should be looking straight. The nurse may also use a stadiometer. Head circumference is checked up to 36 months of age using a paper tape. In order to obtain correct measurements of the head circumference, the measurements must be made above the eyebrows, above the ear pinna, to the occiput. Weight, birth to 36 months. You want to weigh them nude. You need to balance the scale first and make sure that it is 0 before you put the child on it. And then you can weigh them in a comfortably warm room, and of course, always provide privacy. Physiologic measurements. These are key elements in evaluating the physical status of vital functions include temperature, pulse, respirations, and blood pressure. For best results in taking vital signs in infants, count the respirations first before the infant is disturbed. Then take the pulse, followed by the blood pressure, and the temperature is last. If the vital signs can't be taken without disturbing the child, record the child's behavior along with the measurement. So if they're crying, just make sure you document that. Oral thermometers are typically not used until the child is 4 to 5 years of age. Know that the rectal temperature is about 1 degree higher. The axillary temperature is about 1 degree lower than the oral temperature. Respiratory rate. This decreases with age. Infants are predominantly diaphragmatic breathers. It is important to count for a full minute. Their breathing may be irregular and they are obligatory nose breathers. By the way, it is normal for their rate to be, their pattern to be irregular. The heart rate, this decreases as they get older, and we want to take this for 1 full minute. At the age of 2, it is then okay to take a peripheral radial pulse. The blood pressure increases with age. The BP varies with the cuff width. So if you use a blood pressure cuff that is too large, the blood pressure will be artificially low and incorrect. If you use a cuff that is too narrow, it will be artificially elevated and the blood pressure will be incorrect. The bladder width should be 40% of the arm circumference. The bladder should cover 80 to 100% of the circumference of the arm. So physical assessment. The general appearance of a child is a cumulative subjective impression of the physical appearance, state of nutrition, behavior, personality, interactions with parents, the nurse, posture development, and speech. So these are all of the components that we want to take a look at. The general appearance, skin, hair, nails, hygiene, lymph nodes, head, neck, eyes, ears, nose, and throat, chest, heart rate, respiratory rate, heart sounds, lung sounds. The abdomen, it's very important to inspect, then auscultate, followed by palpation and percussion. We will look at the genitalia, back extremities, the posture positioning, movement mobility, gait, strength, and symmetry. A neurological assessment will assess balance, coordination, reflexes, and cranial nerves. Please remember that you want to assess painful areas last, as well as areas that are invasive, like looking up the nose, in the eyes, into the ears, or into the mouth. Next, we're going to talk about growth and development during infancy. Age 1 month. Physical. Here we can expect a weight gain of 150 to 210 grams, which equals 5 to 7 ounces weekly, or 1.25 to 1.5 pounds a month for the first 6 months. Height gain is 2.5 centimeters, or about 1 inch a month for the first 6 months. Head circumference increases by about 1.5 centimeters, approximately 1 inch a month for the first 6 months. Primitive reflexes are present and strong. And remember, they are obligatory nose breathers. Gross motor. Here they can turn their head from side to side when prone, and they lift their head momentarily from the bed. They do have a marked head lag when pulled from a lying to a sitting position. They do have an asymmetric tonic neck reflex, also called fencing position, when they are laying on their back. Fine motor. This is your hand-finger use. Here we're going to see a hand that is predominantly closed. Grasp reflex is strong. Sensory, they're able to fixate on moving objects in a range of 45 degrees when held anywhere from 8 to 10 inches away from their face. Visual acuity is about 2100, and they will follow a light to midline. Know that when they hear a voice, they will quiet down. They do cry to express displeasure, they will make small throaty sounds, and they'll make comfort sounds during feeding. In terms of socialization cognition, they watch their faces intently as he or she talks to them. Age 2 months, the posterior fontanelle will be closed. Gross motor, which is our large muscles, when they're prone, they can lift their head almost 45 degrees off of the table. When they are held in a sitting position, their head may be held up, but it may actually bob forward. Fine motor. Here the hands are often open and the grasp reflex is fading. Sensory, binocular fixation, and convergence to near objects is beginning. They will search visually to locate sounds, and they will turn the head to the sound, to the side when the sound is made at ear level. Vocalizations, note that these are different from crying. They may coo and they vocalize to familiar voices. It is at 2 months that we begin to see that social smile in response to various stimulation. 3 months, the primitive reflexes are fading. Gross motor, they're able to hold their head more erect when sitting, but it still may bob forward. They're able to raise their head and shoulders from a prone position to a 45 to 90 degree angle from the table, and they can bear weight on their forearms. Fine motor, they will actively hold a rattle, but they will not reach for it. Here is when the grasp reflex is now absent. They will clutch their own hand, pull at blankets and clothing. Sensory, they will follow an object to the periphery at 180 degrees. Vocalizations, they will coo, babble, and chuckle. They tend to have less crying during periods of wakefulness by the 3-month time frame. Socialization cognition, typically they will stop crying when the parent enters the room. They can recognize familiar faces and objects, and they show awareness of strange situations. Age 4 months, drooling begins. Gross motor, they have almost no head lag when they're being pulled to a sitting position, and they balance their head well in a sitting position. They're able to sit erect if they are propped up. Also, they're able to raise their head and chest off a surface to an angle of 90 degrees. They roll from back to side. Fine motor, here they'll try to reach objects with their hand, but they actually will miss it. They'll overshoot it. But they will carry objects to their mouth. They can grasp objects with both hands. Sensory motor, binocular vision is fairly well established. They can focus on about a 1.25 centimeter or a half-inch block, and they're beginning to develop that hand-eye coordination. Vocalizations include N, K, G, P, B. They will laugh aloud. In terms of socialization, they demand attention by fussing. They don't want to be left alone. They like socializing with other people. They're starting to show memory. 5 months, birth weight doubles, and we're starting to see signs of tooth eruption. There should be absolutely no head lag when a child is pulled to a sitting position at the 5-month age range. Here they can turn over from their abdomen to their back, and they can even put their feet towards their mouth when they're supine. Fine motor, they will use a palmar grasp using a bidextrous approach using both hands. They might play with their toes. They may take objects to their mouth. They can localize sounds made below their ear. They can make vowel cooing sounds interspersed with consonant sounds like ah, goo. Socialization cognition, they will smile at a mirror image. They enthusiastically are playful, but they do have rapid mood swings, and they're beginning to discover parts of their body. 6 months. Here, physical growth rate may begin to decline. The weight gain of 90 to 150 grams occurs weekly or 3 to 5 ounces for the next 6 months. Height gain is about 1.25 centimeters, which is about a half an inch monthly for the next 6 months. Teething may begin with the eruption of 2 lower central incisors, and so here you might notice chewing and biting. Gross motor, they will roll from their back to their abdomen, and when they're held in a standing position, they can actually bear almost all of their weight. Fine motor, here they like to hold their bottle, and they may grasp their feet and pull them to their mouth. Sensory, here they will adjust their posture to see an object. They can localize sound made above an ear, and they will turn their head to the side and then look up and down. Vocalizations, they're imitating sounds. They will babble, and they'll have one-syllable utterances like ma, moo, da, die, hi. And they take pleasure in hearing their own sounds. This is a self-reinforcement. Socialization cognition, they recognize their parents and they're beginning to fear strangers. Okay, they'll hold their arms out to be picked up. They will imitate a cough or a protrusion of their tongue. They do have frequent mood swings, so they can go from crying to laughing very, very quickly. 7 months, eruptions of upper central incisors will occur. Gross motor, here they can sit in a high chair with their back straight. They can sit leaning forward on both hands, and they will crawl, but remember, crawling is when the abdomen is on the floor. Fine motor, here they can hold 2 cubes more than momentarily. They may bang a cube on a table and rake at small objects. Sensory, here, when you say their name, they will respond to it, and they're starting to have taste preferences. Vocalizations includes producing vowel sound and change syllables like ba, ba, da, da, ka, ka, and they will talk when others are talking. Socialization and cognition, here they're having really an increased issue with being afraid of strangers, and they become very fretful when their parents disappear. They do like to play peekaboo. They'll try to get attention by coughing or snorting. If they don't like something, they will keep their mouth closed. Age 8 months, the parachute reflex appears, and this is when you feel like you're going to fall and you quickly raise your hands to catch yourself. So this appears at that time. Gross motor, they are able to sit steadily, unsupported. Fine motor, they're beginning to have a pincher grasp using the index, 4th, and 5th fingers against the lower part of the thumb. They will persistently reach out for toys that are out of reach. Vocalizations, they'll make consonant sounds like T, D, W. And socialization cognition, they're now starting to respond to the word no. They dislike getting dressed and having their diaper changed. 9 months, here you have those upper lateral incisors beginning to come out. Gross motor, this is where they're creeping on the floor. So creeping is different than crawling, because creeping, you have their hands and knees are on the floor, but their abdomen is off of the floor. They can sit steadily on the floor for a prolonged period of time. They can pull themselves to a standing position and stand holding onto the furniture. See, here they're comprehending the word no in terms of vocalizations. In terms of socialization, they're beginning to show fears of going to bed and being left alone. And also those little rascals will put their arms in front of their face to avoid having it washed. Age 10 months, the labyrinth writing reflex is strongest here. And this is when the infant is in a prone or supine position and they're able to raise their head and they're trying to put their body back in the correct position. Gross motor. Here they may stand while holding onto furniture, but they'll sit by falling. While standing, they may actually lift one foot to take a step. Fine motor, they can grasp a bell by the handle. And now they are saying mama and dada with meaning. They comprehend bye-bye, and they may actually say an other word as well. This is when they will inhibit their behavior to the verbal command of no and their name as well. They enjoy games like patty cake, but also please note that if an adult is angry around this child, that they will respond to that and they will cry. They enjoy looking at and follow pictures in a book. 11 months. Here, those lower lateral incisors are erupting. Gross motor, they are cruising, which is when they are holding onto furniture as they're walking. Fine motor, this is where they have that nice, neat pincher grasp with the index finger and the thumb. Socialization cognition, they will roll a ball to another person on request. They will anticipate body gestures when a familiar nursery rhyme or story is being told, like this little piggy went to the market, and they know that you're going to be tickling them. They might like to play games like up, down, or peekaboo, and they will shake their head for no. Age 12 months. Here their birth weight is tripled and their birth length has increased by 50%. So if this child was born 7 pounds, now they are 21 pounds. If they were 20 inches long when they were born, now they would be 30 inches because it's their increased length by 50%. So 50% of 20 is 10, and you would add 20 inches plus the 10 inches. Head and chest circumference is equal at this time. Prior to this, the head was bigger than the chest. Here they should have about 6 to 8 teeth. The anterior fontanelle is almost closed. Typically, the anterior fontanelle closes anywhere between 12 and 18 months of age. They may walk with one hand held, and they may attempt to stand alone momentarily and may attempt a first step alone. Fine motor, they try to insert a pellet into a narrow-necked bottle, but they fail at this time. They should be able to turn pages in a book, but it's many at a time. Vocalizations, here they normally will say 3 to 5 words besides mama and dada. Remember, comprehending the meaning of several words occurs prior to verbalization. So they may understand what you're talking about, although they may not actually be able to say those words. They will imitate animal sounds, and they do understand simple verbal commands like give it to me or show me your eyes. Socialization cognition. Many may develop a security blanket habit or a favorite toy. Note that the term transitional object can also be used. Next, we're going to talk about injury prevention during infancy. You're going to notice that this is divided by developmental accomplishments. So first, we're going to address birth to 4 months of age. Major developmental accomplishments include the involuntary reflexes, such as crawling reflex, which can propel the infant forward and backward, and the startle reflex, which may cause the child's body to jerk. They may start rolling over, and they have an increase in hand-eye coordination and voluntary grasp reflex. So injury prevention. Aspiration is not such a problem here, but we do need to begin thinking about anticipatory guidance. Do not shake baby powder directly on an infant. You want to place that in your hand and then place it on the skin, and then store the container closed and out of the child's reach. You want to hold the child for feeding upright. Don't prop the bottles. You don't want them to aspirate. Know the emergency procedures for choking, and then if you're utilizing a pacifier, you want it to be a one-piece construction with a loop handle. Suffocation and drowning. You want to keep all plastic bags stored out of the infant's reach and discard large plastic garment bags after tying in a knot. Don't cover a mattress with plastic. Use a firm mattress with absorbent pad underneath the sheet. Use a firm mattress with loose blankets, and you really don't even need the blankets. No pillows. We're doing this because we want to avoid issues with sudden infant death syndrome. Make sure the crib design follows federal guidelines and the mattress fits snugly. Sometimes people want to use a crib that is handed down because it's been used in the family for generations. Note that that may not be safe. Crib slats should be less than 2 3/8 inches or 6 centimeters apart. Position the crib away from other furniture and away from radiators. We don't want them getting burned. Please do not tie pacifiers on a string around an infant's neck. If you use bibs, make sure you remove them. Do never, ever, ever leave an infant alone in a bath, and do not leave infants under the age of 12 months of age on an adult or youth bed unattended. Falls, always raise crib rails. Never leave infants on a raised, unguarded surface. When in doubt, put them on the floor. Restrain child in an infant seat and never leave a child unattended while the seat is resting on a raised surface. Avoid using a high chair until the child can sit well with support. Poisoning is not so much of an issue here. Burns. Installing smoke detectors in the home is important for the entire family. You want to use caution when warming formula in the microwave. This is actually not recommended because you can end up having hot particles in the child's mouth can be burned. Always check the temperature of the liquid before feeding. Check the bath water. Do not pour hot liquids when an infant is close by, such as sitting on your lap. Although you should never be smoking around an infant or in a house where an infant is located, if someone is doing something like that, please make sure if they're holding the infant, the hot ashes don't fall on the child. Do not leave an infant in the sun for more than a few minutes. You want to keep them covered with a blanket. Wash flame retardant clothing according to the label directions. Use cool mist vaporizers. These are safer than the hot ones. Don't leave a child in a parked car, ever. Check the surface of a car restraint because the car seat may be hot and we don't want to burn them when you're placing them in the seat. Motor vehicles. You want to transport infants in federally approved rear-facing car seats in the back seat, ideally in the middle. Do not place an infant on the seat or in the lap. Don't place a child in a carriage or a stroller behind or in front of a parked car. Also, please do not put children or infants in a front passenger seat with an airbag. Bodily damage, you want to avoid sharp, jagged objects and keep diaper pins closed and away from the infant. 4 to 7 months of age. Here the major development accomplishments are: they can roll over, they sit momentarily, they can grasp and manipulate objects, they can resecure a dropped object, they have well-developed hand-eye coordination, they can focus on and locate very small objects. Mouthing objects, meaning putting things in their mouth, is very prominent. They can push up on their hands and knees and crawl backwards. So here, injury prevention includes aspiration. So keep buttons, beads, syringe caps, and all small objects out of the infant's reach. Keep the floor free from any kind of small objects. Don't feed infants hard candy, nuts, foods with pits or seeds, or whole or circular pieces of hot dogs. Any kind of food that is circular in nature and in general should be cut into small, irregular pieces. Exercise caution when giving teething biscuits because large chunks can be broken off and aspirated. Don't feed the child while they're laying down. Inspect toys for removable parts. Keep baby powder if used out of reach. Avoid storing large quantities of cleaning fluids, paints, pesticides, and other toxic substances. Discard used containers of poisonous substances. Do not store toxic substances in food containers. And discard used button-sized batteries and store new batteries in safe areas. Make sure that you know the telephone number of a local poison control center. This is a telephone number you should have programmed into your cell phone as well as taped to your refrigerator. Suffocation. You want to keep all latex balloons out of reach. Remove all crib toys that are strung across the crib or playpen when the child begins to push up on their hands and knees or when they're 5 months of age. Falls. You want to restrain a child when they're in a high chair and keep the crib rails raised to their full height. Poisoning. Make sure that the paint for the furniture or the toys that the child is playing with doesn't contain lead. And please place toxic substances on a high shelf or in a locked cabinet. Hang plants or place them on a high surface rather than having them on the floor. Burns. Keep faucets out of reach. Place hot objects on a high surface and limit exposure to the sun. At 6 months, you can start applying sunscreen. Bodily damage. Give toys that are smooth and rounded, preferably made of wood or plastic. Avoid long pointed objects as toys. Avoid toys that are excessively loud. Keep objects out of the reach of children when they are sharp. 8 to 12 months. Here the major developmental accomplishments are creeping and crawling, standing, holding onto furniture, standing alone, cruising around furniture, possibly walking, possibly climbing. They can pull on objects, throw objects, pick up small objects. They do have a neat pincher grasp. They explore by putting things in their mouth. They don't like being restrained. They explore away from their parent, and there's an increased understanding of simple commands and phrases. So here, aspiration. Keep lint and small objects off of the floor, furniture, and out of the reach of children. Take care in feeding solid table foods to ensure that the pieces are very small and irregular chopped. Don't use beanbag toys or allow the child to play with dried beans. Suffocation and drowning. Keep doors or ovens, dishwashers, refrigerators, coolers, and front-loading washers and dryers closed at all times. If storing an unused appliance, such as a refrigerator, remove the door. Supervise contact with inflated balloons. Immediately discard popped balloons and keep uninflated balloons out of the reach of children. Just so you know, latex balloons used to be the #1 non-food items small children choked on. You want to fence swimming pools and always supervise anytime they're near water, cleaning buckets, drainage areas, and toilets. Keep bathroom doors closed and eliminate unnecessary pools of water. Anytime a child is in a bathtub or in any kind of water, you want to keep one hand on them at all times. Falls. Fence stairways at the top and the bottom if the child has access to either end. Dress an infant in safe shoes and clothing so they don't trip. Avoid walkers, especially near the stairs, because we don't want them to fall. Ensure that furniture is sturdy enough for the child to pull themselves up to a standing position and cruise. Poisoning. Administer medications as medications. Do not tell a child that you are giving them candy when you're giving them medications, because this can increase risk of poisoning. Replace medications and poisons immediately after use, and make sure that if it has a child protective cap, that this is also used. In general, we say poisons and medications should usually be placed, actually should always be placed in a locked cabinet. Burns, place guards in front of or around any heating appliances, fireplaces, or furnaces. You want to keep electrical wires hidden or out of reach. We don't want them chewing on them. Place plastic guards over electrical outlets, or you can place furniture in front of them. Keep hanging tablecloths out of reach because we don't want a child to pull down on the tablecloth and then have hot stuff fall on them. As you can see, the type of injury at risk is most significantly determined by the child's development. The leading cause of death in unintentional injuries in your infants is suffocation. Let's talk a little bit about car seat safety. Car seats do expire, typically after 6 to 7 years. Don't get one from a secondhand store or a garage sale. If the car seat is in an accident and it was empty, it is still good. If somebody was in it, however, throw it away. Do not remove the material off the car seat. Wipe it with a damp towel. Removal damages the integrity of the car seat. Place a car seat directly on the car. Don't place a towel or a blanket underneath it. Place the actual car seat restraint belt over thin clothing so the restraint clip is at chest level and close to the skin. If it's cold, you can place a blanket or a thick jacket over the belts. The chest clip must actually be at the axilla level. If you get pulled over, you can get a ticket if it is not. Rear-facing infant seats must be placed at a 45-degree angle to prevent airway obstruction. So please, I understand sometimes a child may be sleeping in their car seat. Don't leave them in the car seat. Take them out and always supervise a child when they are in a car seat. Children under 2 must be in a rear-facing car seat unless they are 40 pounds or are 40 inches tall. The CDC recommends 2 to 4 years of age utilizing a car seat. Booster seats can be used typically after 4 years of age until 8. Now, if a child is 8 years old and over and they're not 4'9" or 100 pounds, then they should still utilize a booster seat. But once they are 4'9", typically then they can sit in the car seat and sit in a car with a regular seat belt. The thing is you want the seat belt on the bones. You don't want it to go across the neck or the abdomen. So you want it low on the hip and going across your collarbone. Children must sit in the back seat until they're 14 years of age. And there is some talk of actually making it 16 years of age. So in summary, some growth and development things that we have gone over, and there'll be a few new things here as well. The birth weight doubles by 5 months, triples by a year, quadruples by 2.5 years. The height for 6 months, 1 inch per month, and then 6 to 12 months, the height increases by 1/2 inch per month. The birth length increases by 50% at a year and then doubles by 4 years of age. A child is about half of their adult height when they're 2 years of age. The head and chest are of equal measurement at age 1, and then by the time the child is 2, the chest is larger than the head. During the first 6 months of life, fetal hemoglobin is replaced by adult hemoglobin. So only after this can hemoglobin disorders be diagnosed. Usually one gives oral iron or iron-fortified formula or iron-fortified rice cereal between 4 to 6 months of age. As we said before, they crawl about 7 months to 8 months of age on the floor, and then they creep about 9 months of age. The rib cage is very flexible, so if they are in respiratory distress, you may see retractions. They do diaphragmatic breathing until they're about 5 years of age, and then it progresses to more thoracic as they get older. Abdominal distension can impede breathing for infants. The short straight eustachian tube, which is close to the ear, can allow infection from the pharynx to travel to the middle ear. Majority of digestive processes are immature and don't really function at birth and begin functioning about 3 months of age. The liver is immature during the first year of life. An increase in adipose tissue during the first 6 months of life insulates the body against heat loss. Renal structures are fully mature at the end of the second year, and tears typically develop between 2 and 3 months of age. At 4 months, drooling begins as a part of the teething process. Teething may begin approximately 5 months of age, and you might see drooling beforehand. You'll see an increase in finger sucking, biting on hard objects. They may be irritable, poor sleep, and refuse to eat. The lower incisors typically erupt, followed by the central upper incisors. Pain can be caused due to inflammation, so you can give cold, not frozen, teething rings. You can also wrap an ice cube in a washcloth and then just rub it on the gums. Again, we want to be very careful not to cause any kind of freeze or burn. You can use a baby Oragel that is benzocaine free. So we don't want the benzocaine in the baby Oragel. Baby Tylenol or baby Notrin also can aid for pain management if they have the inflammation. The number of teeth formula is the age of the child in months minus 6 equals the number of teeth. So as we mentioned earlier, a 12-month-old, if you minus 6, should have 6 teeth. But remember, teeth kind of come in, they don't just magically appear. So know that this is a general developmental tool. Fluoride, 0.25 milligrams, may be started at 6 months to 3 years of age if the water fluoride level is less than 0.3 parts per million, or the child is only breastfeeding or only drinks unfluoridated bottled water. Fluoridated bottled water is available for drinking and mixing formula. Play during infancy, birth to 6 months. So you want to stimulate the different sensory areas for the child. So visually, you can use nursery mobiles, unbreakable mirrors, see-through crib bumpers, contrasting colored sheets, auditory music boxes, musical mobiles, bells, and then rattles. Tactily, you can use a stuffed animal, soft clothes, a furry quilt, and soft mobiles. Kinetic, holding the child as you're rocking them. You can have a rocking crib or cradle, and then an infant swing or a weighted or suction toy. 6 to 12 months of age. Visually, here you can use colored blocks, nested boxer cups, books with bright pictures, simple take-apart toys, a jack-in-the-box. Auditory, rattles of different sizes, shapes, and tones, squeaky animals, recordings with light rhythmic music. Tactile can be animals that have different textures and dolls, sponge toys, floating water toys, teething toys, books that have textures such as fur and zippers. And then kinetic, here you can have activity boxes for the cribs, push-pull toys, and a wind-up swing. Next, we'll talk about breastfeeding and bottle feeding. So we all know that breastfeeding is best. I know that in your OB class, your instructor talked about all of the different benefits of breastfeeding. So I do want you to know all of those, but I'm only going to touch on a few here. So remember, it is a perfectly fit nutrition for an infant. It increases immunity and passes immunoglobulins to the infant for the first 4 months. It also promotes maternal bonding. They're less colicky. It is free, and you can even pump and refrigerate it for multiple days and freeze it for later use. The only downside of breastfeeding is often the mother, if they are physically breastfeeding, you're going to be having to breastfeed very, very frequently, just every few hours, and you cannot measure the exact amount that the child eats. But know that this is why you will count the diapers. Bottle feeding. So really the benefit of bottle feeding is that we do know exactly how much the child eats and they feed less often. But the problems are they can have allergies, they can have an increase with colic, it's expensive. You need to buy the formula, bottles, the diapers. You may need to use bottled water if you have high amounts of lead where you live. So always remember, breastfeeding is best. After feeding the baby, you can position them on their right side to facilitate digestion. But if a child is sleeping, remember, babies, we put them on their backs to sleep. Again, this is to help prevent issues with sudden infant death syndrome. FYI, you only give water or a pacifier when putting a baby to sleep. You don't want to give sugar water or juices in a bottle due to tooth decay. This is also called bottle mouth syndrome. Typically, we don't give any kind of juice until the child is weaned to a sippy cup. No honey until after 12 months of age due to botulism. No whole milk until 12 months of age due to its low iron, zinc, vitamin C content. It is also hard to digest and has a high renal solute load. So feeding babies, they don't really have a mature swallow ability until they're about 4 months of age. So we really don't want to feed solid foods until then. Also, they have an insufficient amount of pancreatic enzymes, amylase, and the enzyme that initially digests carbohydrates until 4 to 6 months of age. So during the first 6 months, typically we will say that they shouldn't have any more than 32 ounces of formula during a 24-hour period. The first month, typically they eat every 2 to 3 hours, 2 to 3 ounces. Then at like 2 to 4 months, they'll eat 3 to 4 hours, 3 to 4 ounces. And then about 4 to 6 months, it's about 100 milliliters per kilogram in a 24-hour period. Usually 4 to 5 ounces, 4 to 5 times a day. And this is when you'll begin that iron fortified rice cereal. This has a very low allergen potential and it has the iron. Iron supplementation may be necessary for infants that are exclusively breastfed after 4 months. Extra fluids are not necessary before 4 months of age and can actually cause water intoxication. Vitamin D and B12 may be necessary if the breastfeeding mom is a vegan or is not eating an adequate diet. Know that when we're starting to feed children solid foods, we want to feed the solid food first because we want them to be hungry. So you'll give them that before you breastfeed or give them the formula. Also, you will put the food on the back of their tongue because we don't want them to spit it out. Typically, we start with 1 to 2 teaspoons, increasing to 2 to 3 tablespoons of feeding. You want to give one food every 4 to 7 days to check for allergies. Do not introduce foods by mixing them in the formula or the bottle. We want them to learn to enjoy the taste and the texture of the food. Iron fortified cereal should be given daily until 18 months of age. In general, when we think about feeding infants up until a year of age, really their big nutrition is their breastfeeding and their breast milk. The solid food is more introducing them to the different tastes and textures. So solid food, here we can give it between 6 and 12 months, and when we're adding it, typically we're going to start with some strained, pureed, finely mashed foods after we give the iron fortified rice cereal. You can start with things like vegetables and fruits, things like 6 to 8 months of age. You would use things like applesauce, bananas, and pears. These are usually well tolerated. You don't want to give them canned or fruits or vegetables because if they're not specifically for infants, they could have a high lead content, plus they have salt, sugar, and or preservatives, which they don't need. Often we will start with vegetables like strained peas or spinach because the infant will be more receptive to that. If we start with fruits, because they're sweet and they taste good, they may be less receptive to the vegetables. So usually we do vegetables and then the fruits. 9 months and over, now we can start giving them meat, fish, and poultry. We don't want to give them fatty meats, and you can prepare it by baking, broiling, steaming, or poaching. And you can even include organ meats like liver, because this has a high amount of iron, vitamin A, and vitamin B complex. If a soup is given, please make sure that all the ingredients that are in that soup are familiar to the child's diet. You want to, if they have an allergic reaction and there are multiple things in that soup they haven't had before, you don't know what was the problem. Also, avoid commercial meat vegetable combinations. Typically, these have a very low protein content. We can give egg yolk and cheese also at this time. Egg whites, here you're going to give more at the 12-month mark because they tend to have a high allergy potential. In general, when we're looking at foods that have a high allergy potential for your infants and small children, they include eggs, cow's milk, wheat, soy, and peanuts. This concludes the lecture addressing the behavioral objectives for week 6. Please note that this is part B. Oh, I said week 6, I beg your pardon. This is for week 1. This is part B. Please be sure to read your textbook and complete all of the assignments for this week to facilitate the utilization of this content and apply it to your nursing practice. Thank you and have a good day. Remember, this is part B for week 1. Bye-bye.